Good evening to the people of Savannah. Thank you very much for coming out here tonight. So this is an MS Views and News Compass to MS Care program. All right, and we do these programs around the country. We do this series, Compass to MS Care, every single month in one location or another, usually in rural America, as well as underserved communities. We've been to some very, very remote areas around the country where internet is not even accessible. So getting the word out and being live streaming during those programs makes it a little bit more challenging. For those that don't know me, my name is Stuart Schlossman. I too have multiple sclerosis. That's another story altogether. But tonight we're here, and I want to tell you that we are supported by Banner Life Sciences, Genentech, Bristol Myers Squibb, and TG Therapeutics. And if you don't know those names, maybe you know better the names of the medications. So Banner Life Sciences is Beferitum, and Genentech has Ocrevus, and Bristol Myers Squibb has Zeposia, and TG Therapeutics has the newest medication that's out there called Briumvi, and I'm sure you'll be hearing about that as well. We also have exhibitors tonight. We have Alexion, Beferitum, which is Banner. We have Bristol Myers Squibb. We have the National Multiple Sclerosis Society is here exhibiting today. We have Genentech and we have TG Therapeutics. All right, so tonight's program, we have Dr. Harvey Samowitz, who's a urologist. He's going to be online first. Online, you all are not going to see him here in attendance. He's going to be doing this virtually from South Florida. All right, he's going to be speaking about the bladder issues and what not to do with bladder issues. Dr. Samowitz will be speaking for 35 minutes, and then we'll do 20 minutes of Q&A. And is Dr. Samowitz online? Is he ready to go?
Hello, everyone. Good evening. I'm going to start off here tonight, and we're going to be talking about the effects and treatment that multiple sclerosis has with the bladder. I'm located in South Florida. So just to give you a little bit of background, you might have noticed after my initials, MD, there's the letters FP MRS, and that stands for Female Pelvic Medicine Reconstructive Surgery. That's a separate board within urology that I went through specialized training, fellowship training, and I had to take exams related to female pelvic medicine reconstructive surgery, but that also includes those things those neurological issues that affect the bladder and urinary system. So those of us who have specialized in this area tend to be the ones that manage a lot of the MS patients. I just want to mention that urinary issues are very common in MS patients, affecting up to 80%. This is in some kind of a neurological problem. So it used to be 10% of MS patients were diagnosed with MS because of urinary issues. But today we're going to talk about the causes of urinary dysfunction related to multiple sclerosis, its effect on patients, and some of the treatment options that are currently available. So the police just pulled me over and said papers. I said scissors, I win, and drove off. I think he wants a rematch. He's been chasing me for 45 minutes. I should mention that you can't be a urologist without having some sense of humor. You have to understand what we do for a living requires some sense of humor. So we use the term voiding dysfunction as a term to describe a range of urinary issues, including overactive bladder, urinary retention, urge incontinence, stress incontinence, and nocturia, which is nighttime urinary frequency. So let's start off with overactive bladder, which is by far the most common. It not only affects MS patients, it affects the general population to a large degree, so that about 48 million Americans suffer from overactive bladder. And this is characterized by the sudden urge to urinate even when your bladder is not technically full. You are urinating frequently and will get up at night more often than needed. Typically, we say that a patient should be urinating about every 3 hours, about no more than 8 times per day, and that at night they shouldn't be getting up more than twice at night. Otherwise, it interferes with the sleep pattern, and that can have detrimental effects. So We see a lot of overactive bladder. It's not always well understood why patients have overactive bladder, but in the MS population, it's related to their neurological disorder. So urinary retention is sort of the opposite of that, where they are unable to empty their bladder completely or at all. And the patients initially may notice a weakened stream, difficulty starting their urination, or having to strain to empty the bladder, double voiding, and they also will end up having urinary frequency and urgency. They're urinating in frequent small amounts and not completely emptying their bladder and not utilizing the full bladder capacity. Urge incontinence is where the bladder basically contracts without the owner's permission. And it's an involuntary loss of urine when a patient experiences a sudden urge to urinate. The patient may experience leakage before they're able to reach the bathroom, so that the bladder is contracting. They may have an urge and they just can't get there fast enough. And the bladder will contract spontaneously, and that is a very common form of incontinence, probably one of the most common forms. Stress incontinence is a little different. Now, stress incontinence is not the stress of having a bad day. It's a mechanical stress. This is the involuntary loss of urine when the patient coughs, laughs, sneezes, lifts, strains, bears down, moves quickly, or engages in other physical activity in which they increase abdominal pressure and the urine drops out. This is due to a weakened sphincter. This is not a bladder problem so much as a sphincter problem, which is the valve that holds the urine in. And when they increase abdominal pressure, the valve is not strong enough to hold the urine, or the valve, the sphincter, is not supported well enough that it's falling down and the sphincter opens and the patient loses urine that way. Nocturia is urinary frequency specific to the nighttime. And as I mentioned before, we don't expect patients to urinate more than twice at night. When they get to 3 times, we usually intervene. And this is probably the most bothersome part of overactive bladder and voiding dysfunction to patients, is the nighttime frequency, because in some cases they're chronically tired, and it often involves their partner if they're getting out of bed or having to urinate while they're in bed sleeping. So multiple sclerosis damages the nerves controlling the bladder and the urinary tract, leading to various urinary symptoms, and the location and extent of the damage determines the type of urinary dysfunction. So patients that have plaques in the brain will have a different problem than patients that have plaques in the spinal cord and lower down in the central nervous system. And so we see a variety of different problems in multiple sclerosis patients depending on where their lesions are. And so as a result, we see not only overactive bladder, we see urinary retention, urge incontinence, stress incontinence, nocturia. And it can change, of course, in the MS patient whose symptoms are changing over time. So it's often complicated to determine what sort of urinary issue they have. So the location and extent in MS, it can be more complicated, as I was mentioning. Sometimes it's due to a overactive bladder and the bladder is contracting. Sometimes it's due to a sphincter that is either too relaxed, or the sphincter doesn't want to relax, remains contracted in spasm. So normally the bladder has to store urine and it relaxes, and the sphincter and the pelvic floor tighten and hold the urine in. That's the storage phase. During the emptying phase, the bladder has to contract and the pelvic floor and the urinary sphincter have to relax to let the urine out. If the two are not talking to each other, we call that sphincter detrusor dysenergia, where the bladder is trying to contract, but the sphincter and the pelvic floor have not relaxed, and the bladder is pushing against a closed outlet, and that does damage to the bladder and causes not only damage to the bladder, but it can also send the pressure, the urine pressure, back up into the kidneys and cause kidney damage. Detrusor hyperactivity impaired contractility is where the bladder doesn't work well and the sphincter doesn't work well. The bladder has two jobs. It's got to store urine and it's got to empty urine. This is where it doesn't do either job well. The bladder is overactive and it gets to a relatively low volume and wants to start contracting too soon. And then when it does contract, it doesn't contract well. It doesn't empty out the urine well enough to push all the urine out. So it's impaired contractility. So this is a problem that we sometimes see in MS patients, and we also see in the elderly, particularly elderly women, where their bladder doesn't store urine and it doesn't empty urine as either. Urinary dysfunction has a significant impact on the quality of life, embarrassment, social isolation, depression. These patients sometimes feel that they're prisoners of the bathroom. They have to do things like toilet mapping when they go to a new location, or they have to know where the bathrooms are. If they're going to drive somewhere, they have to know where they can stop. They do defensive voiding. They urinate multiple times and frequently, even though they don't have to, but to avoid problems. They will also restrict fluids, which is dangerous because they allow dehydration. There's a lot of issues related to urinary dysfunction that patients have to live around their bladder. It becomes the central focus of their lives. It could also lead to urinary tract infections. If the patient's bladder is not emptying well, there's stagnant urine left behind in the bladder. It's a nidus for infection. Kidney damage can occur when the urine backs up to the kidneys, or if they get a kidney infection from an ascending bladder infection. If they're incontinent and they're sitting in diaper long periods of time, the skin starts to break down and they deform, they develop decubiti, and then there's other complications as well. Patients have to make lifestyle adjustments such as avoiding fluids, scheduling bathroom breaks, and wearing protective garments and diapers. Well, beer can do miracles. So there's a use for a wheelchair. The first thing we have to make sure is that the patient is able to empty their bladder at a low pressure, that we can get the urine out. We say low pressure because, as I mentioned, with detrusor sphincter dyssynergia, these patients will void with high pressures, and that high pressure will get transmitted up the ureters to the kidneys and can cause kidney problems. So we have to make sure that the patient can empty to protect their kidneys. We want to make them continent. We want to make sure that if they are emptying their bladders, that we try to keep them as dry as possible or control the urinary leakage. Preservation of the upper tracts, as I said, it's important to protect the kidneys with the urinary issues, and that the bladder itself has adequate storage, that they can control their frequency, that it's socially continent, that they are able to function with a impaired bladder in whatever means is necessary. So the first thing we can try is lifestyle changes. Now, this applies not only to the multiple sclerosis patient, but also to a lot of the general public. So the first thing, obviously, is fluid management. That doesn't necessarily mean to be always dehydrated, but for patients, for example, that are urinating too frequently at night, that have nocturia, we suggest that they don't drink much fluid after dinner, that they try to do their hydration during the day and to avoid too much fluid at night. Some people actually will shift fluids, that they store a lot of the fluid in the lower part of their body due to gravity pulling fluid down. And then when they put their legs up to go to bed, that fluid shifts back into the body and they produce more urine as a result of that. So fluid management is one of the easier things that we can suggest. Certainly caffeine reduction. Caffeine is both a stimulant to the bladder and a diuretic. Bladder irritants. Typically we talk about things like alcohol, which sometimes is also a diuretic, but it can also irritate the bladder. There are certain foods that some people, not all, but some people can be sensitive. Spicy foods, acidic foods, pickled foods can sometimes irritate patients' bladders. Weight loss seems to have an effect on improving bladder function, and bowel management is important. So managing both constipation and frequent bowel movements and fecal incontinence. But certainly constipation will affect the bladder. The bladder and the bowel live in the same neighborhood, and there are reflexes that affect each other, so that if the bowel is not functioning properly, the bladder won't function properly. So quite often I have to speak to my MS patients about bowel regimen. And sometimes they have to set up a bowel regimen so to ensure that they have a bowel movement at least every other day. And then medication changes. There are some medicines that will impact the bladder, in particular things like diuretics, and sometimes we have to speak with their primary care physician or their cardiologist and try to adjust certain medicines to work better for the patient. So as far as treatment options, we can start off with the non-pharmacological, and then we often do have to move on to more invasive treatments. The non-pharmacological interventions would be pelvic floor muscle exercises. Pelvic floor muscle exercises are not intuitive, they're not easy to do, but there are certain reflexes that go on where you can get the bladder to calm down. You can inhibit a contraction of the bladder by doing certain exercises. Now, these exercises, I said, are not intuitive. So to teach someone how to do these properly, we often send the patient to a physical therapist who specializes in pelvic rehabilitation. Just like there's some urologists that specialize in certain neurological issues, there are physical therapists that specialize in pelvic rehabilitation. They go through special certification, and it's not always easy. Sometimes I have to hook the patient up to some like EMG monitors, and they'll look at a screen and they'll do biofeedback to learn how to contract the proper muscles and how to relax the proper muscles. Bladder training can also mean when the patient has that initial urge to urinate, they'll try to hold it, try to increase the time to voiding like another 10 minutes, and do that for a week. Each time they have to go, they'll try to hold it for an extra 10 minutes, and then the following week add in another 10 minutes. Double voiding is for patients that don't empty well. They will sit, particularly women, they'll sit and urinate and try to empty, and after they think they're finished, stand up, take a few breaths, relax, and then sit back down again and try to complete emptying of the bladder. If they have very high post-void residuals, this will help them to empty out more effectively. Pharmacological intervention, there are basically 4 generations of medication for the bladder. The first generation is very well known to many patients, oxybutynin. It also is the one that has the most side effects, particularly dry mouth and constipation. And recently we've tried to get away from these types of medicines because they may have some other effects, including central nervous system effects like dementia. So the first generation is oxybutynin. The second generation is Detrol and Sanctura, or trospium and tolterodine. Third generation is Vesicare, Abilex, and I'm blanking on the other one. And then the fourth generation is the most recent generation, and these are quite different. These are not anticholinergic. The fourth generation of medicines are beta-3 agonists, so they have a different receptor, and they work quite well without causing a lot of side effects. The ones that I'm talking about are Merbitric and Gemtesa are the two that are available right now. And these medications theoretically can raise blood pressure a little bit. I have not seen that happen very often, and they really don't have a lot of side effects. And so my go-to medication now is Merbitric. There are some other pharmacological interventions, such as Botox, that works quite well. It partially paralyzes the bladder. If we have a patient who has a severely overactive bladder, we will use Botox up to 300 units, and that gets injected directly into the bladder, and it can even go as far as to partially paralyze the bladder or completely paralyze the bladder, where the patient does not void. They have to catheterize to empty their bladder. But some of these patients would rather do that intermittently, self-catheterize, rather than have incontinence. So sacral nerve stimulation is where we put a small lead, a small wire, down into the pelvis, into where the pelvic nerves are. This is just above the crack in the buttocks, and we put it through the S3 foramen. These are the nerves that go to the bladder. It's a small wire. We do a test to see if the patient does respond to this, and if they do respond favorably, we place that neuromodulator that you see, that's about the size of a quarter. You place that underneath the skin in the upper buttock, and this will control the bladder. It's almost like a pacemaker for the bladder, and it works at two ends of the spectrum, which is very interesting. It works on the patients who have it works at two ends of the spectrum. It works on the patients that have severely overactive bladder that is not responsive to the usual management, and it also works on the patients who have non-obstructive urinary retention. I've done a number of these in MS patients. In some cases, it works initially, and then sometimes doesn't work so well. I have a feeling that in some of these patients, their demyelinated fibers are not able to transmit the electrical impulses so well. So it is a treatment of last resort, but it is an option for some patients, and it's really quite minimally invasive. We do it under sedation, without having to give them complete anesthesia, and when it works, it's a great thing. And then in some cases, we have to go to catheterization. Catheterization is for patients that are in retention usually, and the ideal situation would be self-intermittent catheterization. There are many products out there. They're quite good. The patients will catheterize. It's a clean catheterization. They'll catheterize themselves, drain the bladder, and then throw the catheter away. Some of the catheters now have the bag already attached to the catheter, and they're very convenient. The urine goes into the bag, and you just throw the bag in the garbage. There's others that are very, very small, especially for females. They're called lipstick catheters. They're literally the size of a lipstick. They can carry it in their purse, and it's a very once the patient learns to do it, it's a really simple thing to do. They say it's sort of like brushing their teeth. So it's not so invasive, and even the most reticent patient can learn to do intermittent catheterization. Sometimes the patient is not capable, and we really don't have another choice. We have to leave a catheter in. For those patients, there is the urethral catheter, which is the standard catheter that is placed in the urinary tract. And then for long-term use, we prefer to use a suprapubic catheter. And this is a catheter that's placed between the sort of the belly button, just below the belly button. It is easier to manage, it's easier to change, it's easier to keep clean, and it's out of the way. So in some cases, we do have to use suprapubic catheters. They get changed once a month, and the patients don't seem to mind that too much. They manage with that quite well. In rare cases, there are other surgeries that have to be done, but that's not very common. That's very rare. So in conclusion, voiding dysfunction is a common and significant problem for MS patients. It affects the majority of MS patients, up to 80%. The effects of voiding dysfunction are devastating, impacting the patient's physical, emotional, and social well-being. Treatment options are available, and some of these are not so severe. And once a patient gets used to it, they're quite satisfied with that. And it's important for the patient and the healthcare professionals to work together to manage these problems to improve outcomes. A multidisciplinary approach usually involves the neurologist, the urologist, the physical therapist or physiotherapist, and the caregivers. And this is the most effective management for avoiding dysfunction in MS patients. Next slide. So I'm open to questions now. I think I used up my time.
My question is about performing Kegels and strengthening the pelvic floor.
Do you have a specific question?
Yeah, that's for urinary control.
He wants to know a question. You were only saying that you wanted.
Does that help? And do you recommend that?
Yes,
Okay.
those are Kegel exercises are part of the pelvic floor muscle exercises. And they're usually, those are the Kegels that are usually done by women who have had childbirth and have stress incontinence. So it's not typical for a male to have stress incontinence unless they've had a radical prostatectomy and there's damage to their sphincter. But pelvic floor muscle exercises are sort of similar to Kegels. Now, Kegels are usually where the patient is told, tighten the muscles that stop the stream. So while you're urinating, you might stop the stream. We don't want you to do that on a regular basis. We just want you to do that to learn which muscles you have to use to when you're not urinating. And the Kegel exercise should be done when you're not urinating. Patients don't remember to do them. You got to do them frequently. So you got to do them like 10 times a day. I tell patients to do this when they're driving or when they're when they come to a stop, do their Kegel exercises. When they're reading and they turn a page, do their Kegel exercises. If they're watching television, a commercial comes on, do your Kegel exercises. And there's 10 repetitions for 10 seconds each. Again, though, Kegel exercises are more for females who are having stress incontinence, which is leakage with coughing, sneezing, laughing, lifting, straining, bearing down, jumping, running, straining, and pushing. That's where Kegel exercises are. For a male, there'd be maybe more pelvic floor muscle exercises where we're trying to teach you to create a reflex back to the bladder to calm the bladder down. They're similar to Kegels, but not exactly. So therefore, we often send the patient to a physical therapist who specializes in pelvic rehabilitation, who can teach you how to do these exercises the right way. Many patients just Valsalva when instead of doing Kegels. They're pushing rather than tightening.
Hello, question for, well, I'm a man, so I guess this is a male question. After the bladder has, how do you avoid leakage? The main concern I know I have is after I've used the restroom, did everything I'm supposed to do, go back and then sit down, some more comes out. So that's, I guess it's called leakage. How do we avoid leakage after it's been emptied?
Well, are you talking about post-void dribbling, or are you talking about the sensation of not quite emptying yourself?
The first one.
Okay, so post-void dribbling actually happens to a lot of men, and it's not related to MS. Post-void dribbling is more related to probably enlargement of the prostate. So what happens, we think, is the patient voids, and they think they're empty, and they leave the bathroom, and they get dressed, they leave the bathroom, and then a little more urine, like a tablespoon or so, kind of leaks out afterward. And this is post-void dribbling. What is probably happening, and I don't have a diagram, but let me try to use my hands. So the bladder contracts, and right underneath the bladder is the prostate. And the prostate is enlarged. I'm trying to show you. It's got a space in there, and the urine gets trapped inside the prostate. It's out of the bladder. They've emptied their bladder, but now a little bit of urine is trapped in the prostate. And then when they walk out of the bathroom, that tablespoon or so of urine that's left inside the prostate leaks out. Now, how do we get patients to stop post-void dribbling? It's a tough one. So sometimes we tell them you have to reach down behind the scrotum and try to milk that little bit of urine out, because that's the closest place to your prostate is the perineum. The perineum is the area between the anus and the scrotum. So you kind of push it forward and try to get it out. But there's really not a good solution here, except if you had some kind of prostate treatment, either surgery or medication.
Yeah, I have a question. I have a lot of nocturia at night where I wake up and I go to the bathroom like 3 or 4 times a night. And sometimes I have the urge and it just trickle. So is there something I can do or something I can take or?
Well, again, nighttime is the biggest complaint for a lot of patients because it interferes with their sleep. So the question is, are you having overactive bladder or are you having an underactive bladder? Is it your MS not allowing your bladder to contract fully, that it's still not emptying completely and you're going back to bed with the bladder that's still partially full? That's the real issue to figure out. Most of the time, I would say it's probably overactive bladder, and we just want to get your bladder to calm down and store better. And so some of those things that we talked about for storage, we would probably utilize. But in some MS patients, they don't empty out completely. And in those cases, what they might have to do is make a special effort to empty out. So you might urinate, stand up, take a few breaths, and then sit back down again. Some patients have to do something called CREDE, C-R-E-D-E, and that's where they literally will take their hands and they'll push on their belly and push down to push the urine out to make sure they're getting it all out.
Okay, thank you for that. I'm going to take some questions from online for you to answer, and then I'll go back to the audience again. The first one is, have you prescribed the PureWick system external catheter? And if so, what were the results and have they been favorable?
So you might have noticed that one of my slides, I did throw the PureWick up on there. I think it's a brilliant device. I wish I had invented it. It's quite simply a sponge with a hose that is a vacuum to suck the urine away. It's a very clever little simple device that is for female patients that are somewhat bedridden, and it simply catches the urine after it leaves the bladder and soaks it up and sucks it away before they really get wet and does any harm. So it's a simple system. I like it. I've prescribed it. I found that the insurance and Medicare don't necessarily want to pay for it is the problem.
Okay, next one says, when I use catheters, it seems to get worse. Why is it getting worse?
I don't know. I mean, when you say it's getting worse using catheters are meant to make it better. So if it's getting worse, then you have to figure out what's going on. Is the problem with the bladder getting worse? Is the bladder itself progressing, or is there something else going on? I can't say with little information.
So another person writes, if I use a catheter, will things get better for me?
Quite often when we have to recommend a catheterization, patients do a lot better. There's a large number of MS patients that are doing intermittent catheterization, and they do very well with it. They really do. It's amazing. And once they learn how to do it and they get used to it, it doesn't bother them too much. It's really, they say it's like brushing their teeth. And they do it like between 4 to 6 times a day. And it's like as if they were urinating on their own. They go in the bathroom, they catheterize, and they toss the catheter out. And the catheters are covered by insurance, and the companies that supply catheters are very good about getting the catheters to the patients, and they come in all different types and sizes. And the newest ones, you don't have to use jelly or anything. They're hydrophilic, and so they're very slippery when wet.
Okay, thank you. Next one, concerning the sphincter. People are writing, why does it take a long time to diagnose that there's a weak sphincter? And what's the normal course for finding out if somebody has a weak sphincter?
So a weak sphincter is not really that hard to diagnose. I usually can diagnose it on the first but history usually is the easiest way to diagnose it. But when I do a cystoscopy is where I look inside the bladder with a flexible little scope, and it takes me about 60 seconds. I do it in the office. It's uncomfortable. It's cold and wet, but it should not hurt. And the cystoscopy allows me to see what the sphincter looks like. Does it look closed like this, or does it look open like this? And I can see that when I look inside. That's the first step. The second step is I'll have the patient cough when their bladder's full at the end of the cystoscopy. I'm filling water in their bladder. And then at the end of the cystoscopy, I'll say cough, and I'll see if they leak. And that tells me their sphincter is not strong. The treatment for the sphincter is relatively easy. We either put in a sling, which is a little hammock that goes underneath the urethra. It takes me about 15 minutes, outpatient surgery, very little recovery, smooth. And then the other option is we can inject a bulking agent. Bulking agent is the same kind of thing that you saw at the Oscars. Everybody has their lips injected. It's an agent just to tighten the sphincter, like a washer for a leaky faucet. If their sphincter's like this, we inject the sphincter around with a little bit of the bulking agent, and it tightens it up like a washer for a leaky faucet. And it takes about 5 minutes.
Okay, thank you. All right, just so you know, we have a lot of questions. I got to try to go through these as quick as possible because you're only answering questions for another 12 minutes, okay?
I'll talk
All right,
fast.
first of all, please discuss the use of the TENS unit that's placed near the leg of the ankle that a PT has recommended to reduce the frequency.
So it's not actually a TENS unit. It's actually called PTNS, and it's percutaneous tibial nerve stimulation. There's a couple companies that make these, and they usually require a needle. You can't use a pad. It has to be a acupuncture type needle that goes into the tibial nerve. And then you get hooked up to a little device, a battery operated device, about 30 minutes. And you do this once a week for 12 weeks. And that that stimulates the nerves that inhibit the bladder from below. It's similar to the sacral nerve stimulation, the one I talked about, that is made by Medtronic and Axonics, that we place through the sacral nerve, but it's going up the nerve on their leg rather than down from the sacrum. And these things work so-so. The problem is you have to keep doing these. You do it once you have to do it once a week for 12 weeks. Then you do it once a month. Then you do it once every 3 months, and then you try to stretch out the intervals. But eventually, the patient ends up coming back saying it stopped working, and the question is, do you start all over again? There's a new device that just came out called the eCoin, which takes the place of these treatments where you place a nickel-sized battery by the ankle, and the battery has a sort of a built-in timer that it treats you once a week for a half hour, and the battery's good for several years, like 3 years, and then it has to be changed out. But we haven't had the insurance reimbursement for it yet. So I've been trained in it, but I haven't put any in because it's not paid for yet.
Okay, thank you. Next one I'm going to give you has two different questions, both with intimacy, and one writes, how can I be more intimate with my partner when there's usually bladder issues during and afterwards? And the other person writes that there's a lot of pain and burning in the vagina, and how or what can be used for this.
Okay, so coital incontinence is a difficult problem. Some patients will actually have problems with urinary leak, especially during orgasm. And that can happen to normal patients too, by the way. But the best advice I would say is to make sure you're empty before sexual intercourse, and then try to there's maybe some medications. I mentioned some of these anticholinergics. They work pretty fast. There's some that you can even put under your tongue, and they'll work within a matter of minutes, and they'll calm the bladder down. If it's a sphincter problem, then we have to treat the sphincter, like I mentioned, either with a sling or a bulking agent. As far as the burning in the vagina, there's many reasons why that happens. There's vulvodynia, there's vaginismus, there's dyspareunia. It's a complicated issue as to why some women will have pain in their vagina with intercourse, whether it's muscle spasm or atrophic vaginitis because they're past the menopause or the tissues have gotten thin. Sometimes we have to recommend an estrogen cream for these patients. They have to use that on a long-term basis to build up the walls of the vagina to make them healthier. There's a lot that has to be looked into, not just by a female pelvic medicine specialist. Sometimes I have to send patients to a gynecologist because it's outside of what we do.
Okay, thank you. In short, really short, what do you tell people that have problems after they drink with caffeine, drinks with caffeine?
Go to decaf.
Forget that. They're having urinary problems from drinking the caffeine. What do you tell them?
The caffeine it stimulates the bladder. It's also a diuretic. I mean, that's the nature of caffeine. A lot of people, it doesn't bother them, but some people are very sensitive to the caffeinated beverages.
Thank you. For all the people that have bladder issues during the night and they're up 4, 5, 6, 7, one person writes 10 times a night. Really brief answer, please.
You know, you got to figure out why this is happening. It's most likely overactive bladder. You got to see if it's fluid shifts. Some people literally make more urine at night. We have to sometimes use a hormone called DDAVP, which slows up the production of urine at the kidney level. But the vast majority of these patients have severely overactive bladder, and you have to figure out how to get their bladders to calm down. Sometimes it's medication, sometimes it's sacral nerve stimulation, Botox. We have various things, but getting up that many times a night, is not good for their overall health because they got to get their rest.
Okay, thank you. We have 6 minutes. What can you tell us about the UroLift system, and what can you tell us about Emsella pelvic chairs?
So let me start with the Emsella. The Emsella is an old concept. It's a giant magnet. You sit on it, and it kind of does the pelvic floor muscle exercises for you. I'm surprised that they're still even available. The technology is kind of old. I don't think it's very effective from what I understand. You have to keep going back for treatments, and you're probably better off just doing the exercises on your own. The UroLift is for patients with enlarged prostate, and it takes the place of a TURP, or a resection of the prostate. And it simply is a stapler that we go in with a scope, and we staple the prostate to the sides, holding the prostate out of the way so it's not blocking the flow of urine.
Do you need a prescription for pelvic floor therapy, and from whom?
Yes, you often do need, if you want it to be covered by insurance, you'll probably need a prescription from any physician. But usually you have to know what to write. If you're going to go to your primary, they're going to write for pelvic floor muscle exercises and pelvic rehabilitation. And the reason is for pelvic floor muscle spasm and weakness. And if they put those terms down, if they say that's the reason, then the physical therapy should be covered by insurance.
Thank you for that. Next, so if you were to tell people to cut back on their liquids, what time of night would you suggest?
I usually tell them to slow up their fluid intake after dinner. People want to drink with their meal, that's understandable, but after dinner, slow it down.
Thank you for that. And what do you recommend as the best medications to use for controlling the bladder?
So I did mention Memory-Cognition. That's my go-to medicine. I always have samples in my office, and I give the patient a month's supply to really give them a fair trial of it. So that's my first line medication for overactive bladder, and it has so little side effects. It's very clean. I like that. It doesn't interact with other medicines, and it's just my favorite. Then the other ones, it depends. I mean, again, we don't have any medicines that make the bladder squeeze better, unfortunately. So everything is designed to get the bladder to calm down.
Two last questions. One, do you recommend at all medical cannabis in helping bladder symptoms?
That's interesting. I think I've mentioned this to you before, Stuart. I've always been intrigued with how this might affect the bladder, and I've wanted to actually put CBD oil in a patient's bladder and see how it affects their bladder. But I do clinical research, but I can't find a sponsor for this.
Yeah. You have to ask the marijuana companies, you know? All right. What do we have? We have, okay. Is there a way to, is there anything related to spasticity and bladder issues?
Well, yeah, I mean, spasticity is where muscles contract and don't relax. And so a patient that has a sphincter that doesn't relax has a problem because they'll go into retention from dyssynergia. The bladder contracting and not relaxing, they'll get bladder spasm and bladder pain. The pelvic floor muscles have to relax during the voiding process. So it's all connected. Yeah, spasticity is important for the bladder and the pelvic floor.
Okay, last question. For those that are all going on long car trips and they know that they have bladder issues, what can you recommend for them?
I guess I don't have anything specific for that. This is part of the whole issue, and I don't have anything specific. I mean, I have had patients that like to travel and had MS. I remember one woman, she would, when she would go on cruises, and it wasn't always easy to use a bathroom, she would put a catheter in, a regular urethral Foley catheter, and a leg bag. And then, when the rest of the time she didn't want it, she would take it out and she would use another one. So for her, that was her preference, was to use it. It wasn't my recommendation, but that was what she used to do, is to leave a catheter in for the time being. So if there's a long car trip, I guess maybe put a catheter in for the car trip and then get rid of it.
All right, thank you very much. And sorry if this dialogue upset anybody that's eating dinner right now, but we can't help that. This is the way we had to do the program, all right? Dr. Samowitz, I want to thank you again for being online with us. Of course, you'll be back with us again in the near future, and we'll have to schedule at a time when people are not eating so we can talk about bowel issues. Okay, great. Thank you very much.
You be well. Take care, Stuart. Bye-bye.
Thank you. Have a great day.